I always love these opportunities to be able to share my experiences. And I really try, in these formats to give you as much real, clinical experience that I have practicing over the last 13 years. So we have a lot of material to cover. And like Lisa mentioned, I'll be more than happy to hang out after and answer any questions that you all might have. So buckle up, we'll get right into it, because there really is quite a lot of material when we start talking about ways that we can maintain hard and soft tissue contours. First and foremost, I always like to start with this disclosure. I'm going to present to you a lot of techniques that I use day in and day out, really clinically oriented cases that I hope I can teach you little pearls, whether or not you're new to hard and soft tissue grafting or you're someone that's more experienced. I really hope that you can gain something from this session that you can take back to your practice tomorrow. But with all courses, I always want to say that when you're trying something new, it's always important that you understand, your own experience level. So I just throw that out there. Also want to thank BioHorizons for inviting me to do this lecture. They're a great partner of mine. And so what you're going to see in this session is a lot of different materials, a lot of different products, but these are things that I use in my real everyday practice. And that's really where this session is going to be directed. Just a little bit about myself for those that don't know me. I am a board certified periodontist. I graduated from Nova Southeastern University in my hometown of South Florida in 2009. And then I really went into a little bit of a black hole, I call it, because I was really focused on my family, on paying off my student loans, like most of you. But what I did was I took a lot of photos. And in about 2016, I noticed that social media was starting to become very popular. And that was really why I started my Finodontics Instagram account, because I saw people posting a lot of different techniques and procedures that I either thought were cool and very neat techniques, but maybe not things that we would really use on a day in and day out basis. And so that was really the impetus behind me starting Finodontics. And it really started because I take photos of everything. And if I can impress upon any of you, if you really want to get better, if you really want to learn from your mistakes, I think taking clinical photography photos is going to be great, not just for selling cases and improving communication, but it's really for self-reflection and getting better at our craft. Because this is something that, techniques, materials, they're always getting improved upon. And really seeing my own results and seeing mistakes that I've made in the past and things that worked well is really what drives me and allows me to make those decisions on an everyday basis. Because we've heard this before, but there's really no cookbook. And so you have to understand biology. And so with that said, I always like to start this type of a lecture off and just making sure that we all understand how amazing the human body's potential for healing really is. And this is a case where I didn't do any bone grafting. And as you can see, there may be a very mild buccal defect there, but when we take a tooth out, the body wants to heal, and we can really use that to our advantage. And this is the reason why when we extract a tooth, we can typically go back 3 to 4 months later and know that we're going to have bone, especially in the center of that socket. And me and one of my co-residents, a great friend of mine, Dr. Dan Gober, published this article almost 10 years ago now. And the reason why I think this got accepted for publication in IJPRD was because at the time, we were all doing a lot of bone grafting. And there was a lot of talk about whether or not we need bone grafting, especially around their immediate implants. And what I loved about this case in particular was that Dr. Gober did this surgery, a flapless immediate implant placement in a molar site. And rather than putting a custom healing abutment and rather than loading this case or even putting a healing abutment, what we decided to do was just put a cover screw, place bone graft, no bone graft material, no membrane, and literally allow the site to heal without disrupting the body's own potential for healing. And what was so cool was that we were able to take pictures at 1 week, 1 month, and then again at 2 months. And you can really follow the progression of the healing. And when we uncovered the case about 3 to 4 months later, what we saw was that, sure, we have bone now, around our implant, despite the fact that we didn't use any bone graft material. Now, I'm very particular about the types of procedures and techniques that I will take into clinical practice. And this was a procedure we performed while in residency. But what you can notice in that figure 12 on the bottom left of your screen is that, yes, that we have bone around their implant, but you do start to see that concavity that develops. And so while this is a technique that may be useful for us, The reality is, in most cases, we end up losing bone. And one of my mentors, Dr. Garfinkel, used to say, who do we treat? That's the question. You don't know who to treat, because you have some cases where we'll only get a mild amount of ridge resorption. And that sometimes can be accounted for by, placing our implants a little bit deeper or making a little bit more creative crestal incision, maybe a little bit more palatally or lingually displaced, so that we can account for that and have nice soft tissue around our implants. But a lot of the time, this affects how much bone we have and our ability to place our implants in the prosthetic position that we want. And this case I just saw recently, so I don't have the final, but I remember thinking to myself when I saw this patient for a post-op. This was a case who the patient had a tooth extracted many years prior. And I remember seeing this patient in the chair and thinking, oh, there's plenty of bone, there's plenty of tissue. I don't even need a CT scan because I just know there's going to be enough. And that's really the kiss of death, because the soft tissue can oftentimes look relatively thick, but without that CT scan, you don't know what's going on underneath. And sure enough, while I had enough bone at that marginal level to be able to place my implant, I know that I have that very deep, severe buccal concavity, and I'm going to have a fenestration defect of that implant when I place my implant without doing any additional grafting. And so in the ideal world, this would have been preserved initially, and this would become a very easy procedure, a very easy implant placement. And so we're going to talk today a lot about how to do that in very simple, predictable ways. And I think we can oftentimes complicate this process. And the techniques I'm going to show you, like I've mentioned already a couple of times, these are things that I do day in and day out that work for me. And what I love about it is that there's less pain, there's less swelling, discomfort, less morbidity for patients, but it's also much easier for me. It allows me to do a lot more surgery and take on a lot less risk. And it's not just about the bone. As this photo shows you, it's the soft tissue defect. And you can see that from this view. This patient clearly has a very high smile line, but you can see how thin, how you can see the gray tone in that area of tooth number 7, that's edentulous. So if I were to just kind of ignore the fact that we don't have that soft tissue, no matter how strong my implant is, no matter what type of implant I use, it's going to osseointegrate, but it's never going to look natural, which is what we all want for our patients. We want things to look really, really natural. And this is no surprise, because we know that there's a normal healing pattern that the body goes through when a tooth is extracted. And I always explain this to patients, that the body is just way smarter than we are. It knows when that tooth gets extracted, and we can have a wide array of shrinkage that occurs. And this shrinkage is going to affect our ability to place our implants in the future. And this is a typical scenario that we'll see, where we'll have 40 to 50% of the ridge loss, up to 6 to 12 months. And that's not really a long time. So a tooth gets extracted, a patient decides that they don't want to do a bone graft, or maybe they weren't offered the plan of doing a bone graft at the time of tooth extraction for socket preservation. And we end up in a scenario where our implant needs to go. We can clearly see there's just not enough bone to work with. And so this has been detailed by plenty of authors. And so it may be obvious, like in the previous case, or it may be a case like this, where we're able to place our implants in that prosthetically driven position using a surgical guide, but we can see very clearly that we have a very, very thin buccal bone. And so sure, this is an aesthetic issue, but now we know it's also a functional issue. And a great author, Dr. Monhe, has reported on this, that there really is this critical bone thickness that we need of at least 1.5 millimeters to 2 millimeters. Luckily, there are great techniques that are very predictable that we can use to regenerate this lost bone volume. And we can do this prior to implant placement. In many cases, like in the one I'm showing you, I actually performed that guided bone regeneration procedure at the time of the implant placement. And that requires a little bit of experience to know when it's worth taking the shot to do that simultaneously versus doing it two-stage. And hopefully we'll have a little bit of time towards the end of this discussion where I can show you some of those techniques to regenerate lost bone. But I have to be honest with you, if I can do it in a preservation fashion without having to perform ridge augmentation, I'm going to have a much easier, day at work, and my patients are going to love me because there's much less discomfort and morbidity associated with it. Because when you are trying to regrow a body part, that's what I always tell patients, we're literally regrowing a body part. We have a lot of requirements, right? We need to maintain that space, which sure, we can do that with particular graft materials, but we need to confine that bone graft to the defect. And then one of the requirements of the past principles which I think is the most critical when we're trying to regrow bone and grow bone outside of the housing, is that we need primary closure. Okay. And there's not just one material or technique that we can use for this. Here's 3 different cases that I treated, in the last year. And in one case, I'm using a resorbable collagen membrane. In another case, I'm using more of a titanium mesh type of material. And in the third case, I'm using a plate of bone from the patient's ascending ramus, known as like the Corey technique. And so all of these techniques work. I assure you that they all can work very, very predictably. But in each and every one of these cases, I have to get primary closure. And that is the difference between ridge preservation and ridge augmentation. Because once we need to get primary closure, that means we need to manipulate the soft tissue. We need to perform periosteal releasing incisions, and that's what causes trauma. And so here's a perfect example of that, a case that I treated a couple of years ago, where in the posterior site, we clearly don't have those requirements of the critical bone thickness satisfied. Now, I can perform this ridge augmentation relatively simply. I can adapt, particular bone graft, maybe use a little bit of autogenous scrapings mixed in with that particular graft material. I can lay a collagen membrane over the defect. In this case, I stabilized it with a suture. Not always necessary. I will talk about this a little bit later, but it's not always necessary. But the bottom line is I have to then get primary closure. Okay. And when you get primary closure, this is what happens. We've completely moved the mucogingival junction. We've gone ahead and now we've thinned the tissue just by the nature of having to coronally position and get primary closure. We thinned the tissue. So why did we do it? We did that because we were thinking only about the bone. And you can see here, we have a tremendous result. We now have plenty of bone to work with. We've reestablished that normal anatomy. But when you take a look at the buccal view, you can clearly see that we still have work to do. We have to now go back and think about how we're going to modify that soft tissue. And so there's a lot of ways to do that. And there's been a lot of amazing doctors throughout the world who have talked about this. We really want to avoid this from the beginning. And if we have to augment the soft tissue, this is a consideration that we want to take into account from the beginning. Because later on, sure, we can go ahead and adjust this later on, but it's certainly easier if we can maintain the soft tissue and really trick the body into growing more soft tissue. And that's really what I want the focus of most of this lecture to be. In this particular case, we went ahead and used connective tissue to augment that soft tissue. And as you can see, the pre-op view versus the post-op view, where we're going to go ahead and uncover our implants. In this case, I placed my incision to expose my implants much more palatal so that I could actually move some of that tissue to the buccal. And then that also gave me access to the connective tissue, this really nice thick connective tissue under that palatal flap that I was able to use and anchor to the buccal side. And we can get good results this way, sure, but this is additional procedures. And I am fairly certain that, this patient had more discomfort, more morbidity than they would have had if I would have had a better way to maintain this from the get-go. And so, what I want to focus on is maintaining hard and soft tissue contours. I think that's a realm that is often overlooked because we're often so myopic and we focus on the bone when it's really the soft tissue that determines, how stable and how beautiful things look when we're finished. And so the first step in this is not throwing bone into a hole. The first step in this is really realizing that, like we talked about already, sure, the body wants to shrink the bone as soon as we take that tooth out. And so there is a normal pattern of healing that's going to occur. But we also have to look at these pre-op CT scans. We have to analyze the patient intraorally and take a look at their anatomy, because patients that are thin to begin with, those patients are going to shrink even more. And then let's not forget that the teeth that we're taking out are not healthy teeth. These are teeth that oftentimes have large infections, whether it's from periodontal disease or a history of root canal failure or chronic apical periodontitis. So these are teeth that have infections to begin with, oftentimes with pathology. But the other thing that's often overlooked is that we tend to ruin and destroy buccal plates if we're not careful when we're extracting teeth. So we have to get really good at extracting teeth in a very atraumatic fashion, or as atraumatic as possible, in order to be able to perform much simpler ridge preservation procedures. And so the best tips that I have for people that are getting into augmentation so that they can start placing more implants and have their implants be more predictable is twofold. First and foremost, never begin an extraction without initiating some degree of mobility. And I think that's very important, because if we start grabbing teeth with forceps and all of a sudden now we're staring at root tips that are, very deep, very apical, it's going to be a lot harder to now loosen up those teeth. And then the second thing is that you need to be patient and allow time for biology to help. And what I mean by that is that once we start putting a little bit of pressure on a tooth, whether it's with a forcep or whether it's with an elevator or a very thin elevator is typically what I'll use, we get a little bit of mobility. And if we're a little bit patient and wait 2 or 3 minutes, what you'll notice is that the tooth will actually get more loose every time you go back to start working on the tooth. And I've seen some studies on this, and they report that it's because hyaluronic acid will actually fill into that PDL space. And I see that clinically all of the time. So be patient, and I'll think about every case and the path of draw that you're going to have for that tooth. Because once we start being a little bit aggressive, and it only takes a second, and you hear that buccal plate fracture, then all of a sudden the procedure becomes more of a ridge augmentation as opposed to a socket preservation, which is a lot more predictable. And so the other trick that I have in the instruments, in talking about the instruments that I use, is I very rarely will use periotomes anymore. I like to use a 15C blade, and I'll use this 15C blade almost as a periotome, and I'll very slowly work my way around that PDL space. So I'm going to initiate this into that PDL space, making sure that I'm inside of that PDL space as I walk my way around the tooth, maybe 1 or 2 times. I can also feel with this instrument whether or not I have any mobility. And I think that's very important. The other thing that I'm going to recommend, especially for immediate implants in the anterior sites and for socket preservation in interior sites, is to consider what forceps you're using. And I know everybody's familiar with Ash forceps, but a lot of us use this in dental school or in our residency. And then we get out into the real world and we kind of, overlook it. Well, there's a reason why this instrument was designed, basically, because if you look at the anatomy of the teeth that we have to work with, 90% of the teeth we're going to be extracting will have conical roots, and these conical roots are going to be much more amenable to extraction if we're using a rotation movement. So really, other than the upper premolars and molars, we're going to be using a rotational movement. And in fact, most of the molars I extract, even maxillary molars, I'm sectioning. And so sure, I'm not going to be using an Ash forcep because you don't really have access, but we're still going to be rotating those roots out of the socket as opposed to using a buccal palatal movement. And so that's very, very important. And so because we can use this rotational movement, I want to use an instrument that allows me to maximize the torque that I can get in that rotational movement. So when you look at any other forcep that we have in our kits, they're basically aligned this way with the beaks parallel to the working length. Whereas when you look at the Ash forcep, we have this long moment arm, and that allows us to use our shoulder basically for rotation as opposed to just our wrist. And for those of you that haven't been using Ash forceps for your extractions, I want you to go into the office tomorrow and get a nice pair of Ash forceps, because like I said, for every tooth, premolar to premolar, with the exception of maybe the maxillary first premolar, which is either usually bifurcated or has some sort of figure 8 structure, we can really use this Ash forcep and rotate teeth out of the socket. If we are having a hard time rotating teeth out of the socket, not only will I use this 15C, but I will also use this. This is the most valuable tool that I have. It's also the least expensive. It's an 859 Brasseler burr. So basically what this is the longest, thinnest diamond burr you can find. So you can imagine how if I do have a tooth that fractures deep in the socket or in the alveolus, I can always trough around that root tip with this 859. If we don't have a long enough diamond, we're not going to be able to get deep enough to be able to trough. So I will typically use this. And if I don't have a fracture of the tooth, but I just can't grab it with a forcep and I need to remove bone somewhere, I can use this in the PDL space. So I'm not really removing bone. I'm removing the most minimal amount of bone as possible into that PDL space. And that allows me a little bit of space so that I can get a purchase point using the bone as the fulcrum. And usually I'll use a luxating elevator like this to get some movement. Okay. So those are some tips that I think are very, very important. Now, when we're actually talking about doing our bone grafting and preserving our sites, we can certainly do this without a flap. And typically in the anterior, that's what I'm going to try to do. But we can also raise flaps to do this. Now, I always like to review with people, it's different when you're actually grafting within a socket. What we're really doing is we're performing socket preservation. We're preserving what's there. And that code is typically an ADA code of a 7953. When we're actually growing bone outside of the housing, that's no longer really considered a socket preservation procedure. That's really more of a ridge augmentation procedure. Now, whether or not I'm going to get primary closure after performing either one of these types of procedures is really not dependent on whether or not I'm using either code. It's really dependent on a lot of other factors that we're going to talk about. And I think that's really the key, because like I mentioned, once we start trying to pull for primary closure, that's when we have issues with patients having morbidity after the procedure, and also needing additional procedures to get the patient back to a position where they have normal anatomic contours. So one of the most popular questions I get is this, do I always bone graft following an extraction? And I have to say, the majority of cases I do. And even in this example, where I like to call these patients Clydesdales, they just have so much bone. But when you look at the tooth that's extracted here in the upper right, you can see the buccal plate is very thin. And for me, this is such a simple and safe procedure and inexpensive procedure that I can perform this service for my patients in a manner that I'm basically degranulating the site very well. I'm putting particulate bone graft into the defect, into the site. And in some cases, I don't even need a membrane. If my buccal plate's intact, I'm a big proponent of not necessarily placing a membrane. In this case, I did have a very thin buccal plate. There was sort of a green stick fracture. And so I did lie a PRF membrane over that buccal occlusal line angle, but I'm not getting primary closure. But you can see 4 months later, we have tremendous bone. We've completely preserved that buccal occlusal line angle, which is really what we're trying to do when we're performing socket preservation. And when you look at the post-implant placement radiograph, this is the reason why I always bone graft, because there's always other things going on. And for me, I don't want to lose any bone. Once I start losing bone, now I'm starting to think about having to do internal sinus lifts. I'm starting to think about, other things. So I want to do the most simple thing, the thing that's going to be the most predictable as possible. And for me, if I can do this at the time of tooth extraction, that's what I'm going to do. And there's plenty of studies on this. When you look at the numbers, sure, they're not dramatic, right? The control group in this particular study, they lost only 1.5 millimeters more than patients that weren't bone grafted. But you have to understand, we're dealing in millimeters. So the difference between me being able to place a 10 millimeter implant versus, let's say, an 8 millimeter implant without entering into the sinus, that's pretty important for me. So, I'm always looking at that and thinking to myself, we're dealing in millimeters. In another study, the control group, which wasn't bone grafted, had significantly more marginal bone loss. And the site that was grafted had more improved aesthetic outcomes following treatment. And so this is a procedure that can be done pretty much by anybody if you know biology and if you follow the rules and if you don't overcomplicate your life. And so I want to show you how I do this, day in and day out. Now, there are some situations when I won't bone graft, particularly when I don't have enough soft tissue to work with, or I've just lost so much bone that it's really not going to benefit me to graft at the time of tooth extraction. And in these cases, sure, go ahead, extract the implant or the tooth. And you can see here 6 weeks later, now we have brand new soft tissue to work with. This wasn't soft tissue grafted or anything. This is just allowing the body to heal. The epithelium will migrate over that exposed bone. And now we can move forward. This is something that Dr. Boozer, who's sort of, one of my heroes, will do all the time. And he will then re-enter the site and maybe even place an implant at the same time as doing bone grafting with simultaneous treatment, because now he has soft tissue to work with. And he doesn't have to manipulate the soft tissue quite as much because we have more to work with. This is a very common question. Is there an increased risk for implant failure in sites that have chronic infection? And I have to tell you, I did a literature search for this, and there's really not, based on the literature. We have very high success rates in sites that have chronic infection. But I will say, there are certain prerequisites. We have to completely degranulate the sites. And these patients are also put on antibiotics. And I think that's very important. There is a bit of stir and a bit of chatter nowadays about, grafting sites that have previous endo infections, especially these diffuse infections. And I think these cases are ones where I definitely second guess, and I start thinking to myself, well, maybe I'd better off extract these teeth, let the hard tissue and the soft tissue heal, and then we can reassess whether or not this patient's a candidate. Because this study here by Flanagan does show that, long term, we have these bacteria that may stay dormant under the socket. So I think that is important to consider. But for me, if I can really degranulate these very, very well, then I'm more prone to grafting. If this is a site that has active suppuration, I'm really thinking about, doing this in a much slower fashion. And I think there's something to be said for that. Of course, antibiotics are critical. I also look at whether or not patients are, for instance, allergic to penicillin. I learned this in 2004. Wagenberg had a great study where he analyzed about 2,000 implants, and he found that patients that were allergic to penicillin, or I should say reported an allergy to penicillin, had a 3 times greater risk of bone graft and implant failure. And I think that's really telling. And I challenge you all to go look at your cases where you've had implant failures. And almost every one of those cases, for me, it's typically a patient who's taking clindamycin because they were told that they were allergic to penicillin at some point. Something that's completely changed my practice is I now send those patients for allergy testing, because there is a lot of literature that's telling us that only 10% of patients that think they're allergic to penicillin are actually allergic. And so, we're afraid to give penicillin, and we should be if a patient's reporting an allergy. But if you start referring these patients for allergy testing, most of them are going to come back that they're not actually allergic. And of course, there's a lot of lit now about how ineffective clindamycin is. So, everything's sort of come full circle, but this isn't a new thought. This has been known since 2004. So now that we can sort of understand, when and where we want to graft, let's talk about the ideal scenario first, and then we'll start talking about a little bit about, variations to that when we're missing a buccal plate, when we have a dehiscence or a fenestration defect. Okay. So first and foremost, if I could do every case this way, I would, for 2 reasons. Number one, I find that these surgeries are very rewarding, right? And they're also easy. I think clinically and technically they're easy. I'll show you how I do these types of cases. But these are cases that build your practice, because patients are so happy that, they have minimal discomfort, minimal pain, and they actually have that immediate gratification because you're able to give them back a tooth right away. And so this is the dual zone protocol. And I'll mention this again a little bit in a couple slides, but basically what we're doing here is we're using those tricks that I just taught you to extract teeth atraumatically without any incisions, without raising flaps. Because if we can do that and we can completely degranulate that socket and bone sound and know that that buccal plate is intact, we can go ahead, irrigate our sockets, and then we can evaluate those socket walls. And in most cases, we have plenty of bone palatally. And obviously a CBCT image like I have here is very valuable to see where our bone is. And if that's the case, then we can really consider placing our implants immediately. Placing our implants immediately has been made a lot easier in the last 10 years because every company has basically come out with much more aggressively threaded implants. Most companies have a tapered implant that allows us to get very nice primary stability. And I'm a huge fan of a platform switch implant. So this implant in particular is the Tapered Pro implant from BioHorizons. But there are other ones out there that are very similar in that they all have that same sort of design that allows us to get great primary stability, which we all know is key for immediate implant placement. And so one of the things that I think has changed a lot, especially from when I was in residency which was 13 years ago to today, is that we don't need such large implants because of this more aggressively threaded design. We're able to place more narrow implants. And I think that's really beneficial because we want to have a nice jump gap. We don't want to be dealing with a situation where we're placing implants that are too thick, not really being able to pack bone into that horizontal defect dimension that Tarnow talks about. And for that, most of the time I'm using a 3.5 or a 4.2 implant. For lateral incisors, some centrals, I am using a 3.0, but it's very rare for an anterior tooth that I'm going to use anything larger than a 4.2 implant. And I'll tell you, even for length, I'm not terribly crazy about super long implants. I think if we were using an implant that's 10 to 12 millimeters long, in most cases, we have very, very good stability. Sure, we can jump up to a 15 millimeter implant if we have the space for that. That will give us more primary stability, which is nice for immediately loading. But I will say 99% of my cases, 12 millimeters is as long as I go. And this is a very important trick because we all know that we want that cingulum access when we're placing our implants immediately. But if we just sort of start to create our osteotomy right into that palatal wall, orienting that Lindman burr or that pilot drill into that cingulum access, what ends up happening is we slide right off of that palatal wall. And you can see what happens. We end up moving buccally. And all of us have done this. We've all seen this. When we think the implant placement was perfect, the case goes to get restored and the case comes back and it's cement retained. Why is it cement retained? Because we had that incisal access hole. And so, sure, nowadays we can use angled screw channels, and that's fine. I do that quite a bit for cases where we're just not able to get that cingulum access. But I think it's very possible to get that right angulation if we are thinking about how we're going to create that osteotomy from the beginning. So it seems counterintuitive, but what I like to do is use that pilot drill or that Lindman burr, and I go in almost at a 45-degree angle to my purchase point to create that purchase point. And at that point, I can then change my angulation. And now you see I'm in that right spot. I have that purchase point, but I have that cingulum access. And that was a big, I hate to say it, but it was a big change in the way that I did things, because once I was able to create that osteotomy in the right angulation, I'm getting much more primary stability. And now I have that cingulum access. Now, once we do that, sure, we can go ahead and place our implants. And in this case, you'll see I just created this animation to place the implant in that ideal position. But what you can all probably agree on here is that the implant's not deep enough. And that's typically what we do. We don't place our implants deep enough because it's very hard to assess where the buccal bone is. So we have to kind of really spend some time and analyze using a perio probe or even a spoon to kind of realize where that buccal plate is. Because if our implants aren't deep enough, we're not going to get the proper emergence profile. And so I'm usually aiming for about 2 millimeters subcrestal. But if the tissue is very thin, I'm going to go even deeper. Okay, I definitely believe in that. We have to account for the tissue thickness and consider that your implants usually have to go a little bit deeper, because if they're too shallow, again, you're not going to have the right emergence profile and you're going to end up with recession later on, and that's not going to be nice for anybody. So once I get the implant in and I have a nice amount of torque, I do not use an ISQ. I basically allow the implant handpiece to torque out at about 35 newtons, and then I can place the implant to depth with my hand instruments, with my hand driver. And I know at that point that I'm going to have enough torque if the patient's bite is proper. I don't push the limits. If the patient has a very deep bite, I'm not going to risk loading this implant immediately. But if I can get that primary stability, I know that that immediately loaded crown, that temporary crown that I'm going to make, is actually going to preserve the soft tissue and help keep my bone graft in place. So at this point, this is where the dual zone technique comes in. So what I'm going to do is I'm going to graft using a cortical cancellous graft, usually a 50-50 mix. In this case, it was Mineros. And we're going to graft around my implant. Then I'm going to take either a PEEK or a titanium temporary implant abutment. I'm going to place that into the implant. And then in this case, I was able to use actually the same crown that the patient came in with. So this is either a preformed crown or the crown that the patient came in with. And I'm going to bond this together intraorally with some composite. Once we cure this, we can now take this out of the mouth. And this is a big change for me because I really enjoy working, on patients, but I would much prefer, working on the tabletop and doing much of the harder work out of the mouth. And so that's exactly what I'll do. I'll use not flowable composite here. You want to use bulk composite here, and you want to really create that emergence profile. I also highly recommend having an analog holder. Okay, because you want to really make sure that things are polished nicely. And it's very difficult if you're just using maybe an analog of the implant. You get an analog holder, very inexpensive, but it allows you to use a wheel for polishing without having the crown slip out of your hands. And so this is a really good tool that I invested in a couple of years ago. And now I pretty much have them in all of my offices because of how much quicker I can do these procedures. The other tip that I have for those of you that are wanting to do this more is that I would rather spend less time carving and spend more time forming that emergence profile with the composite before I cure it. And so, like I said, don't use flowable here. The flowable is very translucent. I like bulk composite for this But a good prosthodontist friend of mine taught me that I could go onto Amazon and buy a silicone art brush in a pack of 10, usually for about $10 for a pack of 10. And I can use that silicone art brush before I cure that bulk composite to really sort of create that emergence profile. And that's really saved me a ton of time. I'm spending a lot less time carving into the composite. It's really more of polishing that I'm doing than anything else. And this is why they call it the dual zone technique. So I've already grafted that subcrestal zone, right? Now I've created my temporary, and then what I'm going to do is pack more bone around that emergence profile. And really, I'm not expecting that to turn into bone, but it's just going to help support the soft tissue and help to support that temporary. And then you can see this is about 45 minutes after the patient was given anesthesia. From start to finish, the patient's leaving with a immediately loaded crown. Again, the caveat here is, sure, I'm checking the patient's bite. I'm making sure that there's no occlusion. I'm making sure that I had good primary stability. But if we can do this, patients will love you. They'll send every patient your way. Every friend that they know, they'll send to you, because the way these patients heal is tremendous. There's no sutures needed. Patients have no post-operative discomfort other than any discomfort that they would have from just an extraction of the tooth. And you can see at the 4-month mark, we've really tried to maintain the soft tissue as opposed to allowing it a chance to shrink. Because again, once it shrinks, it's very difficult to regenerate. So this is really the ideal scenario where we have that emergence profile, we have that beautiful buccal thickness, and that's a great way to go. In cases where I don't have the ability to use the patient's crown, I think this is a great way to not only have a surgical guide, but also a crown that you can use that, right after the surgery. So I'll use something like this, like a Maryland bridge, a PMMA Maryland bridge that I'll have fabricated in the lab, and I'll drill a hole in the cingulum access to create a surgical guide. And then I can also use this. And because of those wings, it's sort of indexed. So I know exactly how that's supposed to fit into the mouth on the adjacent teeth. And then I'll pick up the implant, the crown, convert it into a temporary, and then cut the wings off. So that's another option for you in those cases. I can also do this in the posterior. Here again, you see I'm just using that same silicone art brush to create that emergence profile. And again, you have that beautiful emergence profile that's been maintained and the soft tissue has been supported. Now, in cases where I don't feel comfortable maybe loading the implant, you can even still use the same technique and then just cut the crown right off at the gum line. Now you have a beautiful custom healing abutment. And that's the next thing that we're going to talk about. So, of course, the question is, can we start this process of tissue training at the time of implant placement if we're not using an immediately temporized implant? And the answer is, of course, yes, we can. There's a lot of different ways of doing this, and I'll quickly run through some of these. This is the eye shell. I get this from Vulcan Labs. It's BioHorizons lab. And basically, it's a shell of the emergence profile. So rather than using a crown to create the incisal edge and then doing the emergence profile out of the mouth, this little eye shell actually fits right into that socket, and then we can fill the gap with our composite. And so I use this quite a bit. They come in different shapes depending on the emergence profile, the different teeth that we're going to be restoring. But this is a great way to really have a nice clean result, as you can see at the bottom of your screen here. And I love this because, again, not as much finishing work needed because that emergence profile is built into this acrylic type of material. I also use a lot of these prefabricated custom healing abutments. This one is called Anatotemp. And so this comes based on the type of implant you're using. You can order based on the connection. So in this case, it's an internal hex. So that's the custom healing abutment that I ordered. And you can see it just fits right into the site and allows us to preserve that emergence profile. And you'll see I use that quite a bit. Here's an anterior case where, sure, I had a lot of discussion with the patient about home care and about being, more compliant. But once we were able to clean them up, I was able to extract the tooth, just like we talked about, and then perform that same dual zone technique. And this is the 2-week post-op. And it's pretty incredible how much that soft tissue will actually migrate coronally and how little of that interdental tissue, that papillary tissue that I lost. If anything, I actually think I gained a little bit of height because I'm supporting the soft tissue with that customized healing abutment. And again, in this case, I didn't even have to make a temporary implant crown. I really preserved that that soft tissue as much as possible. And I'm able to transmit that to the lab with a customized impression post, which I'll show you in a minute, and have the crown fabricated. And again, very natural look in a case that is obviously not ideal, but this is really biomimetic dentistry, trying to match the rest of the mouth. The patient was sent for a custom shade, and he was very happy, but I was happy because it was very easy surgery, very predictable, and the patient had absolutely no discomfort, but ended up with a result that looks as natural as the rest of his teeth. And that's really what we're all shooting for. You do have to be careful if you're using these because, of course, they're timed, right? And so if you place your implant and the timing isn't right, then your emergence profile is going to be rotated. And so, if you're using a hex system like I'm using here, you'll want that flat side of the hex to be directly buccal. I use this in the posterior as well. And here's just an example that I'm showing, because now that we've done all this work to maintain that emergence profile, I'm going to go ahead and create a customized impression post based off of that anatotemp healing abutment. And then you can see the impression that was obtained. Nowadays, most of the impressions I'm taking are using scan bodies. And so what I'll do is the second I take out that customized healing abutment, I'm going to take a scan of that emergence profile, because we all know as soon as you take out that healing abutment, the soft tissue is going to contract and it's going to shrink. So you want to take a scan right away, and then we'll take another scan, and you'll have the labs merge the two scans, and that works really well. And you can see here a very natural result. And that's because the surgery was very simple. There was really nothing to it. I had this customized healing abutment that we used, a prefabricated customized healing abutment, but then we were able to transfer that emergence profile to the lab very simply. So the question is, do we get better results using these custom healing abutments versus using stock healing abutments? And there are lots of different studies on this. And the general answer is that you will get better papilla and more stable bone levels when you're using a custom healing abutment versus stock abutment. Do I always do it? No. And especially earlier in my career, I would use traditional healing abutments all the time. And this is how I would leave it. Right? I would certainly put a temporary, and I'll show you how I do that in a second, a removable temporary, but this is how I would leave it. And I would often get questions from students when I would teach my courses. Well, what happens to the bone graft? Doesn't it just come out? Well, here's 1 week. And this isn't a one-off. This happens all the time. And so you get a little bit of a blood clot. Remember, the patients are usually wearing a flipper or a removable partial denture, and the bone graft just doesn't tend to come out. It really does stay in place. And so this is something that you can do, but it does require a little bit more work later on, because typically you'll have to create some sort of a temporary implant crown to start to preserve the tissue. Now, this is how the patient looked at 1 week. I thought that was pretty incredible. Why did the patient look this way, even though I only used the healing abutment? Well, if I'm not using a immediately loaded crown, I'm going to go ahead and I'm going to make sure that I'm not delivering a partial that looks like this. Okay, this is how they usually come back from the lab. You have to take a little bit of time. Here's another case, exactly how I don't want that partial to look. And so you have to carve it like I'm showing you with that white outline, so that we can preserve those contours, those interdental tissue contours, and support the tissue. So you really can support some of that tissue with a temporary, but it has to be have anatomic contours for that to work. And in this case, the patient ended up having a temporary crown made by his general dentist, and then they went to a final impression. And you can see we did really well with the interdental tissue. And here's the final post-op. So I think that's important to understand. We don't have to use the custom healing abutments, but they certainly help. Well, what about cases where I don't feel comfortable even placing a healing abutment? Maybe I don't have great primary stability. Maybe the patient's bite's very deep, and I'm worried that they're still going to be beating up that traditional healing abutment. Well, you can use cover screw, but you do have to expect that you're going to have a little bit more bone loss over time. And that's been shown in the research. Now, I will do this just like I showed you with my dual zone technique. I'll pack bone around my implants, and I'll even pack bone into that soft tissue zone. Even though I know that's not going to turn into bone, it's still helping to support that soft tissue. Here on the right-hand side of your screen, you can see my temporary denture, my flipper, again, carved that so that I can actually create some interdental spaces for papilla. And I should probably have done it even more between teeth 7 and 8. But here's how it looks at 1 week. And it's incredible. At 1 week, the soft tissue will migrate over. Epithelium travels, at about 0.5 millimeter to 1 millimeter a day. So this will close at about 7 to 8 days. And I have no thought of losing bone graft material. I have no fear of that. So I think this is something that we should all consider for those cases where, we don't have great primary stability, or for whatever reason, we don't want to put a healing abutment on it. You can still try to support the soft tissue. If you just put in a partial denture that has really bad contours, all you're going to be doing is taking that pink flange and you're going to be pushing the tissue out of the way. And again, in none of these cases did I use a membrane, and in none of these cases did I use any sort of sutures or anything like that, because I'm just allowing the body to heal naturally. And here's another great example of that partial or that flipper that's contoured to normal anatomic contours. And you can see a week later, we've still preserved the interdental tissue. And so that's very, very important. And that's something that I want to do in every case. Now, I'm kind of simplifying things because I'm giving you the impression that we don't need to think about soft tissue grafting. And ultimately, you do a lot of these cases, and a lot of them will heal like this. This is tooth number 8. It's an old implant of mine, and we have this beautiful soft tissue contour on the buccal, and that was the dual zone technique. But in a lot of cases, what you'll find is that the soft tissue over time does want to shrink. This is why socket shield, which is where we're actually leaving a fragment of the root in place, has become so popular. I'm not a terribly huge fan of socket shield. I just think that there may be some legal issues later on. And I think that I'd like to sleep really good at night. And so in these cases, you really have to consider adding soft tissue, maybe a connective tissue graft, to your cases. And traditionally, what we would do as a periodontist, we would do this single incision technique, and we would harvest this really thick soft tissue. What I've learned over the years is that it's not really quantity, it's quality. And you can see in this type of soft tissue graft, I have a lot of fat, I have a lot of bulk. And more important than that, most of the time when I'm doing soft tissue grafting nowadays, whether or not it's for teeth or for implants, I'm trying to do things without a big flap. And so this is a perfect example of where I'm going to use some sort of tunneling instrument to elevate that soft tissue without placing incisions. And if you're going to do that, it's going to be very difficult to tuck in that really thick soft tissue graft like the one I harvested prior. I want to harvest a very thin tissue. I want to harvest exactly what I need. And I can use, these same tunneling instruments around teeth. As you can see here, we have this very high quality tissue. Well, why can't I do that around implants? And so the way I harvest my CT grafts nowadays is very different than the way I showed. I will harvest a free gingival graft. And there's really a lot of benefits to this. Number one, it's a little bit counterintuitive. We're thinking now we're leaving the donor site exposed. Okay. And so the thought is, patients are going to have more pain because they have this open wound. Well, in reality, as you can see here, I'm harvesting on a pig jaw in one of our soft tissue courses, but you can see I'm actually leaving tissue on the palate. So the periosteum is not exposed. And to me, that's when patients were getting a lot of pain, when you had exposed bone on the palate. What we're doing now is we're taking the most external tissue, which is much higher quality tissue, less fatty. I'm then using like a collagen sponge, like you see here. In real life, you'll want to press on that to make sure that there's no bleeding or to minimize the bleeding. And then I'll use one single continuous suture just to help keep that collar sponge or that collar tape in place. And to me, that's really the simplest way for me to harvest a tissue graft that I wish I would have learned, 15 years ago, because we're getting such much higher quality tissue. And then the other trick that I learned maybe about 5 years ago is that once I can stabilize this, tape with some single continuous suture, I can use periacryl. Periacryl is basically surgical superglue. And that goes right over the top. And it's super simple to use. You apply it in about 10 seconds. You get really saturated wet gauze and you just dab it. And as you'll see in this video here, you just dab it and it just basically hardens in front of your eyes. And so this will stay there for about a week or so. By the time it comes out at 1 week, just like in those healing of those immediate cases I just showed you, the soft tissue has already migrated in and now patients have very, very little discomfort. Okay. And so this is basically what I'll do to harvest my CT grafts. Well, then I have to remove that epithelial layer. And I do that extraorally. It's very simple to do. There's a couple different ways of doing it. But and I'll show you a tiny little video in a second, but it's very advantageous because you're not harvesting very deep. So you're not risking, a bleed, because the deeper vessels or the larger vessels, we're not going very deep, but we're also getting much higher quality tissue. And this is a perfect example. Again, this is an implant placement, and I wanted to thicken the soft tissue. You can see I harvested from the palate. And basically what I'll do here is I'll place that free gingival graft in between two tongue depressors, and then I can remove that epithelium with a new 15C blade very, very easily. And so now I have this really high quality tissue. It simplifies the harvest, and it also allows us to get the highest quality tissue possible. In some cases, when I'm actually doing a connective tissue graft that's very long span, I'll actually just harvest really thick free gingival graft, and I can use this tongue depressor trick to literally bisect it. And then I have basically two grafts basically from one harvest site. And so these are things that, I'm able to use on all of my cases, not just my root coverage cases, but also on my implant cases. And there is literature here showing that when you're using this periacryl over that collagen sponge, patients report much less pain, much less discomfort. And I know it's a little counterintuitive because you're removing that epithelial layer, but the reality is, you're not exposing the palatal bone, and that's what causes pain. And if you're harvesting this really nice thin tissue, it allows you to tunnel all of your grafts. And so here's another example, just showing an example of the healing on the left side of your screen at about 3 months. And look at a year later, how mature that is. And we even got some creeping attachment because the tissue I'm using now is such high quality tissue. It's not that fatty tissue. So we can take this same concept to our dual zone technique, just like I'm showing you here. This is BioHorizons conical connection implant. And I can just tunnel that under that buccal flap using those same tunneling instruments very, very simply. And you can see now that 2-year post-op, look at the bulk that we have there, almost too much bulk, if anything. It's more bulky than the number 9 site where we didn't have any treatment done. And so this is something that I do add to a lot of my immediate placement cases, especially ones that are, aesthetically demanding, and in cases where the patient's buccal plate is maybe just a little bit thinner than I'd like. Okay. And so we teach these types of procedures in our hands-on courses, particularly the soft tissue courses. I think are very valuable because I'm going to show you in the next 5 to 10 minutes that we have left, some socket grafting techniques and how we should really approach cases where we're not able to place immediate implants. But I think the more critical thing is understanding how to manage the soft tissue. And so I did go ahead and put a promotional code here. So if you're interested in any hands-on soft tissue courses, please feel free to, reach out to us. But really, I think the bottom line is that bone grafting doesn't have to be complicated. And when we start talking about ridge augmentation, again, we have these requirements that we need. We need to stabilize bone grafts. We need to use tacks and screws. A lot of times we have to use non-resorbable materials, and those materials create a lot of risk of infection. And so what I want to do is always try to do things in the most minimally invasive way possible. And so at the bottom of your screen, I have this question of, do we need soft tissue closure for our sockets? And so first thing I want you to do when you extract your next tooth that you're planning on socket grafting is bone sound. You want to know if there's a defect and where that defect is. In this particular case, this patient had an apical fenestration. The marginal buccal bone was intact. And so if the marginal buccal bone is intact, even if I have a fenestration defect, I'm going to avoid lifting the marginal tissue. And that allows me to have access to the defect with a semilunar incision or a vestibular incision. And I can do that if that marginal bone is intact. What is the consequence of this? Well, I get that beautiful result, just like I showed you, of doing the dual zone technique. And yeah, do I get a scar up there? Sure. I have a vestibular scar. The gingiva doesn't scar, but the mucosa does. The keratinized tissue doesn't have elastic fibers, so there's no scarring. You may get clefting, but when you place an incision like this in the vestibule, you can expect some scarring. But look at the papilla, look at the marginal tissue, and that's what we're going for here. So always evaluate where that defect is. Now, if I have a defect of the marginal bone, right, the buccal-occlusal line angle, that's when a lot of us start saying, well, now we need to bone graft it and I need to get primary closure. Again, if you're fighting for primary closure, sure, you'll grow great bone, but you're going to be distorting the marginal tissue. You're going to be moving the mucogingival junction. And more importantly, your patients are going to present to your office at 1 week post-op, and they're going to complain about how bad their week was. If we can do things without primary closure, traditionally we worry about infection, but I have to say I have not seen it at all. And I'm going to show you examples of using lots of different types of collagen membranes in the next 5 minutes, and also, non-resorbable membranes and not getting primary closure. And so even if I raise a flap, getting primary closure to me is the biggest mistake we can make at the time of tooth extraction. So you can see here the classic example of using a non-resorbable cytoplast PTFE membrane. These do work great. I think it's a little bit of a patient management issue, especially for me being, a periodontist who has referring dentists. And a lot of times these patients may disappear, even though you tell them that they have to come back in so you can remove this membrane. And so it's a little bit of a patient management issue, but they do work very well. And so when I have a buccal dehiscence, I can go ahead and I can tuck this membrane in. It has a smooth side and a rough side. The smooth side is supposed to be facing the bone. I can pack my bone into the defect, and I'm going to leave this completely exposed using some single interrupted sutures just to hold it in place. At 6 weeks, this membrane, you just pull it right out. And this is what's going on underneath. You have new tissue that's granulating in. At 4 months, I have this new band of keratinized tissue. I haven't moved the mucogingival junction, and I have really beautiful, healthy bone to work with. And you can see the implant placement at 4 months post-op. Again, in these cases, you do have to remove that membrane at about 6 weeks, but I don't even use anesthesia for this. These will just kind of slide right out. I can also use an amnion chorion membrane. These are very, very popular now. BioHorizons just came out with their own version of this amnion chorion membrane. And why do I like this? Well, I can leave it exposed. It's got growth factors, so it's sort of immunoprivileged. And so it's kind of killing two birds with one stone. And you can see beautiful healing when we're using this amnion chorion membrane. These membranes are a little bit more difficult to handle because once they get wet, they sort of suck down. So I always recommend, no matter what type of an amnion chorion membrane you use, that you use a dry instrument to sort of place it at the site, and then use a second instrument like a Pritchard or a Boozer elevator that's dipped in saline. You can sort of tuck that material under the margins. And then I'll use some very simple form of suturing. I'm going to let this play through, even though we're a little short on time, because I want you to see here that once you go through the process, this 30-second process of stabilizing this, I don't want to go ahead and suture from outside to inside. What I'm going to do is I'm going to suture from inside to outside. And that way I don't pull that membrane out. And so I don't do anything fancy here, just a continuous sort of suture that's going to bite from inside the socket to outside. I'll then move to the buccal side, do the same thing. And then in this case, everything was so stable, I went ahead and continued this suture and went back through the lingual side and then back through the buccal side. And that's when I tied off this suture. Okay. You don't want to put too much tension on the flat margin when you do this. But you can see by doing that, you're not pulling the membrane out. And now we can also use collagen membranes, and particularly when I have a larger defect, that's when I want something a little bit more firm than an amnion chorion type of membrane. I'll use a collagen membrane. The question everybody says, well, you can't leave it exposed. It's going to get infected. It doesn't get infected. We're removing all of the bacteria. All of these patients, especially in my practice, they're put through initial therapy first, right? I'm not doing this on patients who have active periodontal disease, but what we're doing is we're tucking that membrane very simply to create a new wall, a new buccal plate. We're packing our bone into that buccal occlusal line angle, and then we're doing some sort of simple suturing, just like I'm showing here. You can see the 1 week post-op in the middle of your screen. On the right side of your screen, we have 2 weeks later where the soft tissue is granulated in, and we have brand new tissue to work with, and really a perfect site for an implant to be placed later on. Here's a little bit more challenging site where we have, a very friable soft tissue. I'm doing the same thing. This isn't fancy surgery. This is sulcular incision to get access to debride the defect if possible. And that's how the patient leaves, with that exposed collagen membrane. This is a sugar cross-link collagen membrane. I do like this membrane because it's the most resistant to degradation. For these larger defects, I'll use this. But again, regenerating that buccal occlusal line angle is really the most important thing. So when you are bone grafting these, or you're adding your graft, I want you to really pack that graft to the buccal occlusal line angle, and then don't over suture. Just let the suture sort of be passive, holding things together. But it's also important to sort of consider these cases where you are flapping, you may get recession on the adjacent teeth. You have to really think about that. I was very lucky to be working on this case with a prosthodontist who treatment planned crowns on the adjacent teeth prior to me even starting the work. So you can actually get a really nice aesthetic result. But again, very easy procedure for me and the patient. You just have to prepare that we're going to get some recession on the adjacent teeth if we're raising flaps. Alternatively, if we want to really preserve tissue, I have no problem doing this via a tunnel, almost like the soft tissue grafting I showed you on those immediate implants. And we'll use some sort of tunnel instrument to create basically a tunnel to be able to tuck in a collagen membrane. Okay. And this type of membrane, I will typically use something that's a little bit stiffer because I want to be able to tuck that membrane in. The biggest key here is to make sure your tunnel is tunneled laterally enough so that your membrane can actually tuck in without folding up on itself. Once I do that, I follow that same exact protocol I just showed you, where I'm packing bone into the buccal-occlusal line angle, a couple of simple interrupted sutures, and a couple of weeks later, we have brand new tissue to work with. And this heals very, very well. Now, for the last minute or two here, I'll just kind of sum up by saying, does this work in every case, right? Does it work? Can we just do this every time? And, you know, the reality is that every patient comes in with a different clinical scenario. And here's the exact same situation where I did the exact same surgery as I just showed you, but I opened it up to place my implant, and this is where the bone was. And I was actually so disappointed I didn't take a photo. I ended up deciding to place an implant despite the fact that I had this defect. And now I'm going to do a ridge augmentation simultaneously. But start thinking about, why didn't this work like the other one? Well, look at the soft tissue. Look at the patient's biotype. Look at that muscle pull that I had. And more importantly, look in the vestibule. I had this very hourglass, appearance of the bone. And so, yes, there are cases where this won't work, but I'm going to really argue that I still am not upset that I did it this way, even though I didn't get that result that I wanted, because it was an easy procedure for the patient and we gave it a shot. And I think a lot of this comes down to treatment planning and patient management, and explaining to patients that we may need to graft things later. It doesn't mean that the first procedure was a failure, right? Because ultimately, if I was going to try to fix this from the get-go, this defect or this hourglass, shape that the patient had from the get-go, it would have required a very large GBR from the beginning. And so, yes, we can look at our CT scans, beforehand, and we know that, yeah, we may need to graft this later, but it's still worth a shot to be able to do things minimally invasively. And so, yes, there are cases where we will flap things open, and these cases are really more ridge augmentation cases, and we can grow bone outside of the housing in these cases many times, but we have to then consider the fact that we have much more decisions to make in terms of learning how to do periosteal releasing incisions and learning how to get tension-free primary closure, which is key. I don't always get primary closure in those cases. Like in this example, I'm still leaving it exposed. So just because I'm flapping things doesn't mean I'm necessarily going to go ahead and try to get primary closure. But it certainly begs the question, when do we need primary closure? And it's really more for cases where I'm trying to grow bone outside of the housing, and I'm prepared that I may have to do some soft tissue grafting later. So here's probably the last case that I'll share with you, just showing you this very large defect, not getting primary closure, and really allowing the soft tissue to granulate in. Remember, all of these patients are on antibiotics, and it's very important to understand antibiotics after surgery don't really work. You need to have these patients on antibiotics prior to surgery. So even for a large defect like this, these patients are on antibiotics preemptively, if not a day before surgery or 2 days before surgery, at least an hour before surgery. And you can see here in this case, one of the few cases where I actually had to go back and remove some bone because, the patient actually noticed there was a tumor of bone there. So, we do have to overbuild these cases where we have large defects. And every once in a while, you'll get lucky like this and really grow bone outside the housing. And the fact that I had grown so much bone allowed me to go back and get a view of that bone that we've regenerated. But this is not something that I think has to be really that difficult, because it's the complexity of that soft tissue manipulation, I think, that complicates things. And if we can work with biology, use materials that we can leave exposed, it's not only easier for us, but it's also easier for the patient.